Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you back as I highlight a paper of particular interest from the July 2023 edition of the journal. Today I'll be interviewing Dr. Timothy Kwok, who's the first author of an article entitled Changes in Service Delivery and Access to Rheumatologists Before and During the COVID-19 Pandemic in a Canadian universal healthcare setting. Tim, I want to thank you for taking the time to speak to me and to our listeners on behalf of you and the other authors of your paper.
Thanks for the invite.
Perfect. So let's begin. So please review the aim of your study.
So we know that the COVID-19 pandemic resulted in a drastic interruption of health services globally. And even within Canada, medical and surgical services were interrupted. At the onset of the pandemic, many governments, including our own within Ontario, Canada, imposed lockdowns and other restrictions, trying to mitigate the risk of transmission and, when possible, clinically avoiding in-person ambulatory encounters, with the adoption of telemedicine as a means of continuing seeing patients. So we really wanted to characterize the effects of these changes. Therefore, we aim to describe in our paper the changes in service delivery and access to rheumatologists before and during the COVID-19 pandemic periods.
Okay, well, then who did you study? What years were studied? What data did you look at? And did you look at all the visits or specific types?
So we're very blessed to have access to health administrative data and live under a universal healthcare system in Ontario. So we conducted a population-based study where rheumatologists practicing in Ontario were identified using a validated physician database at ICS. The Ontario Health Insurance Plan claims was also used to identify services rendered by rheumatologists to all residents. And we had information on specific fee codes to indicate the date, location of service, type of encounter, including office and telemedicine visits. As during the time of the COVID pandemic, the Ontario government specifically created fee codes that differentiated office versus telemedicine visits. So we split our analysis into distinct time periods corresponding to the pandemic waves and associated provincial-wide health measures, with the pandemic wave onset occurring on March 17, 2020, when the first lockdowns were imposed. So our study period was between January 1st, 2017, so a couple years prior to the pandemic, as well as up to October 4th, 2021, up to the third wave. So we characterized the total weekly number of unique patient encounters by type as well as overall. So that included outpatient office visits, whether that be inpatient or telemedicine visits, so by video or phone, inpatient visits for services rendered to a hospitalized patients, as well as visits to the emergency department. We compiled the data with weekly counts and plotted it in the 1 year prior to the pandemic up until October 1st, 2021. And we took data up prior to January 2017 to look at secular trends and monthly variation in visit rates, and fitted a Poisson model to model specifically new consultations post-pandemic to see if there were any trends with the onset of the pandemic, and also looked at the differences in the transitions between in-person care delivery to virtual care delivery.
Okay, and so now would you highlight the results of the study, volumes, type of visit, etc.?
I think the general message is there was a drastic shift from in-person to telemedicine encounters, and also rates of new consultations, although decreasing in the 3 years prior to the pandemic, continued to decrease. So specifically, in the 1 year prior to the pandemic, there were just above 280,000 unique visits. And in the 1 year prior, there were almost a little bit more than 10,000 fewer new patients seen in the first year of the pandemic, corresponding to a roughly 11% decrease. When the pandemic hit in mid-March, there was also an immediate 76% decrease in outpatient ambulatory visits compared to the week prior, and a rapid rise in telemedicine visits. So telemedicine visits of around 55% were diverted in the first year of the pandemic to a video or telephone-based platform. And this persisted up until September 2021, in the middle, around the second and third wave. and this was consistent over time. In terms of new patient consultations, we saw that the rates were declining in the 3 years prior to the pandemic. And in the first 12 months after the pandemic measures were imposed, we saw that new rheumatology consultations decreased overall, with monthly rates as low as 0.61 of expected rates in May 2020. So to summarize, we saw a drastic change from in-person ambulatory encounters to telemedicine visits, as well as a continued decline in new consultation rates throughout the initial stages of the pandemic.
Two things strike me. One, I was actually surprised to hear that new consult rates dropped prior to the pandemic even. I don't know if you were, but that struck me as something unusual as we worry about access to rheumatologists. And this, yeah, go ahead.
No, I completely agree. And this is kind of a further point to a worrisome trend. And we know from one of the senior authors, Jessica Widdifield's work, that there's a feminization in the workforce although, you know, new rheumatologists graduating every year and entering the workforce, the number of patients and new patients seen on a day-to-day basis are decreasing over time. So this was kind of adding insult to injury on an already kind of fragile rheumatology workforce. Yeah,
no, it's very interesting. And I guess if you can just clarify for me, I was a little bit slow, I guess. As the percentage, how did the slope change of new consults during the pandemic? I mean, yeah, I just didn't quite understand what you said. I apologize.
So the pandemic onset March 2020. Yeah. We looked 3 years prior to 2017 to model the secular rates in the trends. And in one of our figures in our manuscript, you can see the plotted expected rates based on a Poisson regression model. And the observed trends post-pandemic seem the slope to dip further down as opposed to the predicted trends. So although we predicted that new consultation rates would have decreased at the pandemic onset, the expected rates were even lower than we predicted, presumably due to the interruption in health services from the COVID pandemic using this quasi-experimental approach.
Yeah, that's what I thought, but I wanted to be sure. Thanks. And obviously, part of the issue is, and why you did your study, is we do live in a universal healthcare system. And so therefore, how does it compare to other studies?
So at the time when we were conducting this study, couple have been published, and most of the data was from the group in the United States. And obviously it's not a universal healthcare system, but they also saw similar trends in a decreased number of healthcare encounters in patients with rheumatic diseases, a drastic upshift in the proportion of telemedicine encounters. And additionally, they also saw treatment and laboratory monitoring interruptions. And findings were quite similar to studies that have been replicated in Latin America as well as Italy. In terms of a general Canadian context, so Rick Glazier in the CMAJ also published on this and noticed similar trends in terms of when all medical specialties were analyzed, all surgical specialties were analyzed. And this begs the question, you know, in Canada, because we have a universal healthcare system and point of contact is with primary care, are these interruptions because patients were not able to access their primary care physician or nurse practitioner, which is the point of first referral, after which subsequent rheumatology consideration can be considered. Although our aim was not specifically that question, nor do we have the clinical richness in our data set to look into that area, it certainly is hypothesis generating.
Right. And I guess my question, a little more define it, when you do you believe, well, I guess this really goes next. So how do you think the Canadian healthcare system influenced the results? I guess we're specifically talking on the Ontario, right? These are Ontario numbers. Anyway, universal healthcare in Ontario, is it possible to then look at these? I guess my question is it possible to determine whether the changes were proportionately the same, or was there better or worse access? Is that possible to do, compare different studies? I know that might be really hard.
Yeah, I think, each healthcare system and health services are delivered differently in different jurisdictions. I think cross-jurisdictional comparisons might be difficult based on either practice scopes or infrastructure.
Mhm.
I think, and this is just from my personal opinion, I think being in a universal healthcare system might have softened the blow because we were able to transition and had preliminary infrastructure with the OTN, Ontario Telehealth Network, to convert many of these visits to telemedicine encounters, having the flexibility in policy changes. So, one can hypothesize that without a universal healthcare system, the drop might have been even more pronounced. Another point to consider is because we live in a universal healthcare system, we were able to do this study and have the data source to look at it from a population level, which might not be the case when looking at, for example, certain studies in the United States where they primarily looked at community-based registries or network registries instead of the whole statewide or provincial-wide data.
Sure, thanks. And so what do you think are the strengths and weaknesses of your study compared to other studies?
I think, as I alluded to, the population-wide coverage is a huge strength of our study, and the completeness of rheumatology billing claims under one system, which is the OHIP system, and also having a validated physician registry to identify rheumatologists. I think, some of the limitations lie in that because we're using health administrative data, we don't have the clinical input. For example, referral form letters. So we don't know what these referrals are, if a large proportion were due to inflammatory arthritides versus non-inflammatory causes. We are also unable to differentiate between video versus telephone encounters initially because the Ontario government had not initiated the change in billing codes at that time during the first parts of the pandemic wave. And also, I think we weren't able to characterize, because of the lack of billing codes prior to the pandemic, the baseline level of telemedicine provided. Because prior to the pandemic, we assumed physicians were providing telephone advice or virtual care, but without being remunerated, so we weren't able to track these with billing data. So I think all of these are important points to consider in addressing the limitations of our study and how to interpret our data.
Thank you. Great. Anything you want to add that you think we missed discussing?
I think, overall, I think the main message is we identified some dramatic changes in how rheumatology services were delivered in Ontario. And we highlighted market increases and sustained use of telemedicine and a decreased number of new consultations. I think what would be important is to further analyze the upstream factors for these data, as well as assess long-term clinical, economic, and health services implications. And also equally importantly, analyzing how not just the pandemic affected access to care, but also the quality of care provided to our patients with rheumatic diseases.
Yeah, that's a great question. We'll see what happens. I mean, quality is a really hard thing to measure, and I'm not sure we can do it by administrative. I'm not even sure how we really can do it. But anyway, it will be very interesting what happens over time with telehealth.
Yes, for sure.
As you know, patients liked it. A lot of patients really liked it. They really continued to like it. So that might be the one good, the lemonade from the lemon of the pandemic. So we hope.
Yes, and hopefully to mitigate access issues as well, for
Exactly.
the right patient at the right time.
Exactly. So I want to thank my guest, Dr. Timothy Kwok, for taking the time to review the findings of his paper. And to our reviewers, please read the whole manuscript, Changes in Service, Delivery, and Access to Rheumatologists Before and During the COVID-19 Pandemic in a Canadian Universal Healthcare System by Kwok and colleagues, and bring your attention to an accompanying editorial titled COVID-19 Disrupts Rheumatology Care, an Opportunity for Innovation by Drs. Rebecca Granger and Valerie Milne from the University of Otago, Wellington, New Zealand. Both these articles are available for you to read at the journal's website at jroom.org, and they will appear in the July print edition of the journal. And Tim, I want to thank you for joining us, and the audience for joining us, and hope everyone, including you, Tim, will join next month, when I speak to an author or authors of one article of particular interest that I selected from the August 2023. And if I'd love to hear comments on Twitter at jroom or by email at manuscripts@jroom.com. Thank you.
Thank you.